Hello, my friend. Welcome to my show, Chronicles of a Loner RN, and thank you for listening. My name's Ritika. I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today, we'll be talking about the Mental Health and Wellbeing Act and the different aspects of it. I will not be providing a specific story for today, guys, rather the general experience I've had over the last 2 years in ED. This is because mental health patients come to us for help and in a dire time of need, even if they don't know it or don't believe it, which is why we need to respect the patients that I see or you may even see in ED. So we've had many people pass through that are a part of the umbrella of treatment options that are the Mental Health and Wellbeing Act 2022. When people scream, I'm being held here against my will, sometimes it's actually true, but not in the way that is expected. Crucial thing to remember when thinking about the work that emergency clinicians and community clinicians do every day is that we deal with mental health crises, meaning people are at their worst when they present to ED. They may not be in their regular state of mind, which touches on the decision-making capacity we briefly spoke about last week. When this is the case, we as emergency healthcare workers can step in and make the decision to essentially keep someone in hospital, in quotes, against their will, as some would call it. Patients have to pose an extreme or immediate risk of harm to themselves or others to be placed on an order under the Mental Health and Wellbeing Act. When a patient is placed under the care of the Mental Health and Wellbeing Act, they are what is called an involuntary patient. They do not get the choice to withdraw care and leave. While they are being cared for under the Act, this decision is left to the psychiatrist alone, or as well as the mental health tribunal, but we'll get into that. Even ED clinicians cannot undo an order if it becomes apparent later on that someone does not need to be on it. This adds to the complexity surrounding the notion of making a patient involuntary, and we'll discuss the risk of adverse events as a result of being placed on an order and why some patients that present frequently, it is actually advised against placing a patient on the order, under the Act, not on the order, as to not further cause harm to that patient. I should mention that as a voluntary patient, the client retains the independence to withdraw inpatient care and, leave should they choose to. This is because they, while needing help, are not deemed an inherent or immediate risk of self or to others. Of course, on reassessment, if this changes, then we would not let the patient leave and they would be placed on an order to become an involuntary patient. Before we get into the intricacies, though, of patient experiences under the Mental Health and Wellbeing Act, let's discuss the Act itself and what the different orders mean, who can initiate them, and who can put an end to them in the patient's journey. Though, if you would like to learn more about the Mental Health and Wellbeing Act, obviously, mental health and health in Australia is a state-run service. It is managed at a state level, so it's not federal. So each state will have different legislation and different sort of standards that their healthcare workers need to be kept to. So the Mental Health and Wellbeing Act is just for Victorian hospitals. But yeah, if you want to learn about the Victorian Mental Health and Wellbeing Act, just Google it. And the Department of Health website has details on the different acts, the tribunals, and everything I'm going to speak on today, if you want more information. So, there are 5 main types. 5? Are there 5? 1, 2, 3, 4, 5. Oh yeah, I counted right. There are 5 main types of orders. The biggest one we see and use in the ED is an AO. This is an assessment order, and like the title suggests, it is for assessment. It can be placed on a patient by the community mental health team, psych triage, an ED doctor, or even an RN, and obviously a psychiatrist. In my ED, we tend to not put people on AOs. We let psych triage or the mental health team assess and put people on AOs. This is an order that only lasts 24 hours and mandates that the patient must stay in hospital until they are reviewed by a psychiatrist, which is usually in 24 hours. This is done to expedite assessment of those deemed the highest risk, because obviously if they weren't a high risk, they'd be a voluntary patient. Once assessed, and this sometimes happens in ED because of bed block, they will either be upgraded to an ITTO, which we'll discuss in a second, or released from the order to continue as a voluntary patient or discharged back to the community. While the order itself lasts 24 hours to the minute, it can be extended up to twice, so 2 full 24-hour periods, if there is trouble securing a psychiatrist to assess the patient. This can only be extended in hospital and not the community. So basically the maximum time that one can be on an AO is 72 hours, although we try to make sure this doesn't happen as it's not a comfortable experience for the patient. But once this maximum 72 hours is up, a psychiatrist must make a decision regarding treatment. When someone is on an AO, they cannot leave ED as they are considered a high absconding risk and obviously are deemed a danger to either themselves or others. Unfortunately, this also likely means no smokes, which is an understandable cause for concern for a lot of patients. And while we attempt to supplement with nicotine replacement is often not enough, this itself can cause significant distress to the patient and is often the reason for code greys in the department. So for community clients, there is an order called a Community Treatment Order, or CTO. While clients are in the community, they are mandated to comply with the treatments set out in the Community Treatment Order, whether that be a monthly depot injection or necessary psychiatric counseling, stuff like that. This CTO is usually in place for patients that are likely to lose capacity if they do not continue with treatment. Thus, there needs to be supports in place, obviously, to support the patient if they lapse. Patients that are on CTOs are in it for the long term. But usually CTOs are granted by the mental health tribunal, where the treating team makes their case about the patient and the patient themselves have a say, and a governing body that's above the hospitals grants the order or not. These are longer term, like 6 months, and then need review. To get the CTO revoked, the team and the patient go back to the tribunal and provide evidence that the patient no longer needs the CTO. But what happens when, obviously, the patient doesn't adhere to the CTO? So say they don't get their depot, they can't be reached by the mental health team, they haven't been showing up to their appointments, and there is a concern for their health and state of mind. This is when patients on a community treatment order have their order varied, so then they get placed on a varied treatment order. This means that the order itself has been changed to accommodate an inpatient admission. This is instead of putting the client on another AO, as they are already under the Mental Health and Wellbeing Act. So that's sort of the community aspect. Now let's shift back to, say, someone's on an AO. If they are reviewed by the psychiatrist and are it is deemed necessary to have inpatient treatment, then they will get put on what's called an Inpatient Temporary Treatment Order, or ITTO. Basically, this happens when people are deemed not to have the judgment or insight necessary to accept further ongoing inpatient care as a voluntary patient. These ITTOs, or just TTOs, last 28 days. Once the 28 days are up, the team goes to the tribunal and the patient to either get a CTO granted or revoke the ITTO. There is something called a CTTO as well. And similar, if you just smoosh CTO and ITTO together, it's basically an ITTO, or a temporary treatment order, but in the community. Lasts the same amount of time and same sort of processes once the 28 days are up. So what is the difference between a CTO and a TTO? So community treatment order is a long-term treatment plan for the patient and can only be granted by a tribunal, whereas a temporary treatment order can be implemented by a psychiatrist. lasts 28 days before needing to be reviewed by the tribunal and either upgraded to a CTO or revoked. Temporary treatment orders can either be ITTO or CTTO. But if this is confusing you, I suggest you go look it up on Google and have it written down for you, because that makes it a lot easier to figure it out. So while I was on my mental health placement as a student, I actually had a placement in the adolescent IPU, which is inpatient unit. We had a child that was on, I think she was on an ITTO. Obviously, this was quite a few years ago. And she went to the tribunal, her and her parents, as well as the team from the adolescent IPU during COVID. So it was on Zoom. And they managed to get the ITTO revoked. Because I remember celebrating, but I can't remember off the top of my head. But yes, this happens. People, they go and they make a case as to why someone might need involuntary care as opposed to voluntary care. And they need to provide evidence and sort of make a case why the patient cannot basically look after their own mental health. But whilst patients and clients with a range of conditions can be placed on treatment orders, it's usually for those that have low judgment and insight as a baseline, therefore cannot be tasked with maintaining their own mental health. This includes, but is not limited to, schizoaffective disorders, bipolar with mania, psychotic conditions, and other disorders that can cause loss of touch with reality. Of course, this doesn't include drug-induced psychosis, because this is facilitated by the use of drugs. Therefore, it's not really a mental health issue, more or less a drug and alcohol issue, if you get what I mean. So obviously being on an order like these, especially in AO, and also especially when one really believes they do not need it, even though when from an outside perspective it's obvious that they do, is a distressing experience. Not being allowed to relieve stress and anxiety by smoking or vaping, not being allowed outside for at least a full day if you're on an AO, sometimes being shadowed by security, the loud noises, constant beeping, and blinding lights of the ED. It's pretty awful if you think about it from their perspective. This is why, if possible, we try to keep patients as voluntary patients for as long as possible, provided they are willing to stay. This is why you'll hear the phrase sometimes code grey if tries to leave. This is because wherever possible, we too want to avoid making a patient involuntary. But if a patient deteriorates, as in their judgment and insight lowers, or they escalate, becoming aggressive in the waiting room, or becoming a danger to themselves or others, because if you think about it, we have to think about other patients in the department as well, we will place them on an AO and make them involuntary, as there is no choice. But we always like to have the choice, so that's more pleasurable experience for the patient. So when you see someone on an AO, it's because it poses more risk to the patient or to others, such as staff or other patients, to have them be voluntary. This is especially true if they become verbally or physically aggressive, say in the waiting room, where it's an open space and other patients are directly at risk. I forgot to mention the significance of being on an order. It essentially means that the patient has minimal say in the treatment they receive and the measures used to protect them and us. While this sounds pretty bad, it is for the protection of the patient. This means the patients really cannot say no. Say if we need a blood test to rule out an organic cause and the patient is on an order, the patient cannot say no. They do not, while they can physically say no, they do not have a say. We as healthcare workers have the authority under the Mental Health and Wellbeing Act to use any means necessary by which to get this blood test. Under the same sort of umbrella, we can also medicate and sedate patients, and we can restrain patients as well. Although we must try every, and I mean every, least restrictive method first before restraining as a last resort. Specific paperwork must be filled out and patients must be one-to-one after restraint. Types of restraint include chemical restraint and mechanical restraint. These are the two used in ED, but there are other types of restrictive interventions that may be used in mental health units, but I'm just not too sure. We give strong antipsychotics. This, though, is considered treatment and not sedation, even though it has strong sedative effects. But under the umbrella of chemical restraint, we use benzodiazepines to put people to sleep. For chemical restraint to be a restrictive intervention, though, it needs to sedate. Not just put people to sleep, but sedate. Therefore, oral medications are not considered restraint. Stronger medications like midazolam, as opposed to diazepam, are considered chemical restraint. We can also put patients in 4-point restraints to protect us as staff and the other patients. This pins their arms and legs to the bed and is usually done in conjunction with chemical restraint. The patient then becomes one-to-one with 15-minute visual obs needing to be done, frequent pressure area care for the wrists and ankles, and with mechanical restraints, the aim is to get them off them as soon as possible. This usually happens when the patient either becomes less of a risk or they're adequately sedated so that their arms and legs no longer pose a threat to our safety. When using restrictive interventions, specific paperwork must be filled out by the doctor and us, detailing why we have used it, what we had tried before, and what didn't work. The doctor also needs to call the on-call psychiatrist if overnight, or the psych team will call the psychiatrist to let them know that we have used restrictive interventions and why. If restraints stay on for a prolonged period of time, the patient must have a medical review, maximum every 4 hours. That being said, I wanted to say something. Can't remember. I know this sounds awful, and it is an awful experience for the patient to be restrained and sedated. But if you think about it from our point of view, we have other people that are in our care. And if the patient becomes physically or verbally aggressive, then these patients are at risk. That's why we need to make the executive decision to protect everybody else. But yeah, I just wanted to lay out what we do, how we do it, and why we do it in this episode, just so that there's transparency. Sometimes people think that we're taking advantage of them, and people think we're taking advantage of other people, and I just wanted to come on here and say that's not the case. We're doing this because, yeah, like I just said, we have to protect everybody else as well. So, yeah, I just want to be a bit transparent. Let people know what's happening, why it's happening, and how we have the authority to do it, because we do in certain cases. Before we continue, not everyone that needs to stay in ED is under the Mental Health and Wellbeing Act. There are situations where we must keep people in hospital for their own safety. This is called duty of care. We as healthcare workers have a duty of care to keep people safe, and this means not allowing them to discharge against medical advice, sometimes. Situations include heavily intoxicated people, confused people, so like demented people, delirious people, and patients that are deemed not to have capacity to make decisions. Thus, the medical power of attorney must make this decision. There is different paperwork for these patients should we need to use restrictive interventions. There are different standards and forms we must fill out. Although for mechanical restraint, they remain one-to-one with 15-minute visual obs, and obviously the same pressure area care and stuff like that. I recently had a patient that was incredibly ill, hypertensive, hypothermic, and presumably septic, and had just DARMA'd about a week before for the same thing. from another hospital and wanted to do it again that day. For context, we had him on NORAD for his BP, and we tried to wean him off and was unsuccessful. A family member ended up calling and explained to both me and the doctor that he does not have capacity and should not be allowed to make decisions like this, given his last presentation. And I think he had a history of mental health. I think he did, yeah. But the decision was made to keep him under a duty of care until we got psych triage to see him and had his CTO changed to a VTO. Either way, we would not allow this patient to leave for his own safety, with the consent as well of his family and his medical power of attorney. Now, we've spoken a lot about the Mental Health and Wellbeing Act today. Whether you're a healthcare worker, mental health patient, or a bystander that is not privy to the nuanced situation, I hope this gives you a little more clarity as to what could be happening. Not what may be happening. What may be happening. Just emphasis on the fact that you don't know what's going on outside of your own situation. But some key things to keep in mind: as an ED patient alongside someone that is there for mental health reasons, or even a patient under the Mental Health and Wellbeing Act, they may be screaming, they may be crying, they may be aggressive, and the sight of seeing someone sedated and restrained is understandably distressing. But please remember that we are there to help them, sometimes from themselves. I implore you that if you see something regarding another patient, to please respect their privacy, and to 1, not watch, and 2, most importantly, to not record them. Not only will you be invading the patient's privacy, but also the healthcare workers involved in the situation. We had an incident recently where we were attempting to protect a patient from themselves, like physically, and that required us to hold them down until they were free from restraints and injury. Unfortunately, a bystander in the waiting room thought it pertinent to film the private encounter on his personal phone. He proceeded to lie to nursing staff, the doctor in charge overnight, and our in-house security about the recording, even though it was quite obvious that he was recording, according to the triage nurse. Then he explained to the police, who we asked to go have a word with him, that while he had deleted, in quotes, because I personally don't believe that, the footage, he was only recording as he was worried about the well-being of the patient. Unfortunately, the waiting room is considered a public place, and thus we as a hospital and even VicPol do not have the power or authority to forcibly remove images and videos, but we can only ask that the responsible party remove it. Now, while it is admirable that this stranger was concerned for the patient, I want to emphasize that the ED is a safe space for all, while we try our hardest every minute of every day to ensure patients, including mental health patients, receive the best care possible. If the patient themselves believe that they were being mistreated, there are channels for them to express this and to have it heard formally. I'm sure you've seen multiple videos on TikToks and other sites of people filming others, whether that be healthcare workers at work or people in compromising situations. I know I saw one recently, like maybe 2-3 days ago, of, like my little story just then, someone in hospital I think they were brought in by police, and they were like very aggressive to the healthcare workers. And I think the footage came from a police body cam, so I'm not sure about the implications there. But think about if that was you. If you were that person having the worst day of their life and having that filmed and placed on TikTok for millions upon millions, tens of millions of people to see. So while it's all fun and games to view and comment on the situation, please place yourself in the shoes of the person being filmed. Think about how you would feel if a stranger took a video of you at your worst and posted it for the public to see. Before I continue on though, I hope you take this opportunity to reflect on the situations you may have found yourself in, whether that be in ED, whether that be on the streets, in public, and you see everybody filming and you think, oh, I should film too. Please, I hope you rethink your biases and thoughts after hearing this story and this perspective. Whew. Now that this little mini rant is over, let's continue. That's it from me on the topic today, actually. To recap though, we spoke about the Mental Health and Wellbeing Act, the different aspects of it, all the different orders, what it means to be under the Act, the expected timeframes, the authority healthcare workers have over the treatment of people under the Act. We discussed why we like to keep patients voluntary as long as possible, only place them on AOs as a last resort. We discussed restrictive interventions like chemical and mechanical restraint, how it works, what we mostly use and why we need to do it, as well as the aim to get it off ASAP. And we discussed how you, as a bystander or fellow patient or uninvolved healthcare worker, can protect the patient as well by, I guess, not being involved. And I really do hope you reflect and keep this in mind next time you're in ED and you can hear someone screaming, or you're in public and someone is going through a crisis. Try not to make comments. Sorry, one more thing. I'm going to go back to the rant. I find that a lot of patients, when they hear someone screaming across the hall, they find it necessary to make a comment about how we as healthcare workers shouldn't have to deal with it, or it must be terrible to have to listen to this every day, or wow, they sound crazy. These are not appreciated comments. I personally do not acknowledge and I don't respond to comments like this, because I am there for your health. You are there for your health. You are not there to make comments about other people and their state of health. I'm sorry if that sounds really frank and a little bit assertive, but it needs to be said sometimes. And this is a practice I take with me to work every day. And I make sure to educate people that it's not right to comment on the state of mind of others. You are your own person. That means the only person that you can comment on is yourself. So, mind you, sometimes these people can be aggressive and they can say things about other people, but that is what our treatment and interventions are for. So yeah. Okay, now that's an end to my mini rant. Although it's not really a mini rant at this point, it's a full rant. But I hope this doesn't get taken the wrong way, because I personally am just looking out for my patients. And any chance I get to educate people, I will take it. Because I want you to be the best version of yourself. I want me to be the best version of myself I can be at work. And my main value is protecting my patients. So yeah. Anyway, thanks. Thanks for listening and thanks for understanding. So that wraps up this episode of my show Chronicles of a Learner RN. I certainly have learned a lot and I hope you have too. I have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you and see you next time.